Welcome everyone to today's webinar. I'm Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a few questions as part of our Q&A. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. We will also have a series of audience polling questions during today's webinar. The poll questions will pop up automatically on your screen throughout the presentation. When the poll question launches, please select an answer from the options on your screen and click Submit. And thank you in advance for your participation. This session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, I'm pleased to turn the floor over to Emilio to begin today's presentation.
Good afternoon, everyone. This is Emilio Ruoco. I'm the Vice President of Strategic Enablement for PRM and Claims Insights with Healthgrades. And thanks again for joining us. I'll just give you a brief background on me and then turn it over to Jane. I've worked in the physician relationship management and claims data-driven market analytics space for over a decade and largely been focused on health system and provider network strategies. I've been part of Healthgrades since its acquisition of a company called eVariant at the beginning of this year, and I was with eVariant for over 5 years before that. Today, my focus is being a bridge between our prospect and client health systems and our product development, engineering, delivery, and customer teams. What I do is basically help guide how our solutions in this space should evolve and will be built. And I serve as a consultant to each of our clients. I first met our presenter, Jane, today during Henry Ford Health System's evaluation of physician relationship management solutions, and I've really enjoyed collaborating with her and her team on their impressive purpose-driven journey. With that, let me turn it over to Jane.
Good afternoon, and thank you for the opportunity to be with you. It is great to be here. At Henry Ford Health System, I wear two hats. I am the Vice President of Operations for the Henry Ford Physician Network, which is our clinically integrated network, and I am the Administrative Lead for Physician Relationship Management, or what we affectionately call PRM. The two are connected in terms of the roles that I have, and yet are oftentimes uniquely separate. What I'm going to represent for you today is not all of my work. It illustrates a team of people that I've had the privilege to work alongside, and where we are still focused very strongly on this effort today. So as background for you, I have over 25 years of experience in healthcare. Most of my career has been spent at Henry Ford Health System, other than a 3-year consulting stint with Evolent Health out of Arlington, Virginia. Before leaving Henry Ford, I had the privilege of building a referring physician office, or an RPO, as we call it, which was essentially a one-stop shop for referring physicians, built on a solid outreach and support services necessary to deliver on the promise of just say yes to access when a physician is calling to refer their patient. While at Evolent as a consultant, I was able to look at other prestigious organizations across the country, many of whom really yearned for what Henry Ford had built in their referring physician office, but oftentimes the infrastructure just wasn't there. I came back 2.5 years ago, and one of the first things I did was recommend to our chief clinical officer at Henry Ford that we needed PRM. He said, and I quote, "That's great. Exactly what is that?" Our chief clinical officer was committed to physician alignment and to the integrity of referring physician relationships, and we set out on a path to bring PRM to Henry Ford Health System. His executive sponsorship and the partnership of countless others in the organization brought us to where we are today. So let me just sort of frame this up for you. As a consultant, I was often asked where I had worked before. You know, they wanted to know if you had any street cred. And it was very rewarding for me to tell folks that I had come from Henry Ford Health System. I never had to explain where that was. The brand name of Henry Ford took care of that for me. But I will tell you, I am proudly from Detroit. So I'm going to move through a couple of slides here just to tell you a little bit about Henry Ford and just give you some background. And I think it'll help you understand a little bit more kind of how we've gotten to where we are today. So for Henry Ford Health System, we are a 7-hospital system pardon me, forgive me, all of a sudden I just lost my slides for a second. And we are a $7 billion revenue stream, 5 acute care hospitals, 3 behavioral health hospitals, and 250 sites, over 30,000 employees, 650,000 covered lives, and about 3.8 million digital encounters. The part that's really important here is the 1,800 physicians that we train annually, plus the providers that we have on our staff. We're committed to our values of compassion, innovation, respect, and results. And those are at the core of what we do every day. And part of the innovation of Henry Ford is in its name, right? So we're a 100-year-old organization that started its medical group in 1915. And you can see here, and these slides will be available for those who request them, all of the different firsts or innovations that we've done. But early in the 2000s, where the other role that I wear, which is in clinically integrated network and population health, we really invested a lot in those spaces, and we are continuing to bring innovation to our community and to the healthcare industry as a whole, and PRM being part of that. And our most recent innovation this year was a new international hospital for which we have a partnership. So with that, I will take us into why PRM. And so, as I said while I was gone, one of the things that happened is that we had a lot of new individuals that were coming on board in the executive suite, and a new strategic plan was being developed. And a gentleman that I had worked at when I was at Evolent had come to Henry Ford before I returned, and a lot of the work that he was doing centered around why PRM became really important. And Henry Ford had identified that we have multiple areas performing a lot of outreach. People are doing good work, but they're siloed in nature. And that we needed a single structure to try to bring this underneath an umbrella. And then we also needed a platform by which we could track all of this work. In the strategic plan for our growth for the next 5 years, we wanted to increase our covered lives, which, again, really important, from 2 million to 4. But the really important part on this particular slide is to align 150 PCPs and 30 to 70 specialists to support service line and tertiary growth. So Henry Ford was not in the space where they wanted to employ 150 more primary care physicians. And truth be told, I don't know that there were 150 PCPs out there raising their hands looking to be employed. And so what we needed to do was figure out how we could increase incrementally the alignment that already existed, or start to create new alignment. And that's where PRM became really important. We brought together a group of people. We did an entire process of for RFP. We brought in 4 different companies. We had stakeholders from around the organization who participated in that original process. And we started to create some guiding principles. We wanted this to be about way more than volumes. This needed to be deeply rooted in the physicians that we considered our partners, in the patients that we all took care of together in our community. And it needed to also have a lot to do with our communication standards, and that we were going to deliver against our service line growth and strategies. And so these guiding principles are things that we draw back to on a routine basis as we continue to do our work together. And so I would encourage all of you to just take a look at that. And that we also really wanted a single source of truth. I don't know about all of you, but we have a lot of places where we have provider data and source systems. And oftentimes those source systems are in conflict with one another, or they don't keep each other updated. And so this was an opportunity for us to really set ourselves on a path of getting to a single source of truth on our provider data information. So shifting to a data-driven approach. So as I mentioned in my opening, that we had a referring physician office that had been started in about 2008, I believe. And one of the things that we did, this was Henry Ford's an Epic shop now, but this was pre-Epic. And in that referring physician office, we knew we needed something that was going to be able to collect the data to allow us to report on the activity that was coming in from outside the organization. So we purchased a standalone CRM that was customized, didn't speak to anything else, but it allowed us to document the activity that was coming in. It was a duplicative system, which meant that people were documenting in the EMR and then they had to document in the CRM, which is by no means efficient, but it is what we had at the time. And that data allowed us to start to have a lot of insight about where patients were coming from, who was referring them. And I spent a lot of time on the road. For those of you who are familiar with Michigan, we can have some pretty harsh winters here. And so physician leaders and executive leaders and myself spent a lot of windshield time during the spring, summer, and fall months, driving around the state, thanking people for their business, asking them what we could do to garner more business from them. And we used a lot of the data from that standalone CRM, but it only told us what was coming in. It didn't tell us what else was going elsewhere. And so we knew 10 years later, after having returned to Henry Ford and new leadership and a new chief clinical officer, we wanted those insights. And so that's what drove us to be looking for a physician relationship management solution. I think there was a lot to be said in terms of what we were able to do here. We were looking for clarity on provider demographics, what we wanted in terms of documenting all of the activity that was happening. We were tripping over ourselves out there. A lot of folks from service lines or from hospitals were all doing good work and really looking for opportunities to grow the business, but we weren't documenting in a way that we could see each other's work. And we were looking for a solution that would allow us to do that. And back to that market intelligence, we wanted to know what business was going elsewhere. And we wanted to be able to report on a lot of the activity that we were providing. And we were able to choose what was then eVariant, now owned by Healthgrades, and brought that solution to Henry Ford to try to achieve these results.
Jane, if I could ask a question here, could you tell the audience a little bit more about your implementation experience? I know from my working with you that this was a very high visibility project, and I just wanted to know what your team did to set yourself up for success. And now, you know, looking back, maybe what you could have done better, given your experience.
Sure, good question, Emilio. From the beginning, I'd say we had a really strong partnership between IT, clinical, and operations, both at the frontline level as well as at the executive level. At the recommendation of our chief information officer, we hired an implementation partner to work with us and Healthgrades to do the heavy lifting. We hired Slalom Consulting. I would say the part that was interesting and very valuable for them is that they already had a relationship with Henry Ford Health System, and their unique model is that they work where they live. So this wasn't about consultants flying in on Monday and leaving on Thursday, and I say that affectionately, having been one of those in my previous work. What was really incredible is that we brought everyone together and we brought them around the organization for a requirements build. We wanted to understand what it was going to take for a minimally viable product to be able to get it into the hands of the people that were doing the work. And I would say that there was then and remains now a strong commitment. Slalom has long since handed the work off to us. We've hired our own internal team. But we work very closely with the Healthgrades team, and I would say that has probably been one of the biggest strengths. I think one of the things that could have gone better is that we didn't tackle the organizational structure that had been identified that I talked about earlier, and we haven't yet done that today, and that is something that I think that this solution is going to continue to require us to keep asking the question, do we have the right organizational structure around this? Does that answer your question, Emilio?
Great, I appreciate it, yes.
Okay. So as I said, we hired in a new chief strategy officer, and one of the things that was really important is that the commitment on that 5-year strategic growth plan, and then what we were trying to achieve with service lines and how we were trying to drive our presence in the market really allowed for us to invest both in time and in resources into this solution. And everything is data, 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 right? So what are all your source systems? Where is it coming from? What sort of logic ends up having priority over other logic? And we had a lot of people at the table to try to get to this. So we spent the whole first year of implementation. And in that implementation, we had a lot of those key stakeholders meeting on a monthly basis to be providing updates as to where we were, what sort of challenges we were seeing. Those individuals that were part of the implementation executive team really served as folks who could do what I'd like to call road clearance. If we were really running into a bottleneck, they were there to help us clear the lane and get some of the desired results. And we did a lot of teaching in the middle of all of this. You know, every institution and all of us are subject to wanting to, chase after the new solution, that bright, shiny rattle. And it was important for us to make sure that folks understood what this could achieve and what it would not be able to achieve. So we did a lot of education during those, especially those early months. So we signed the MSA in the end of 2018. We kicked off implementation in the second week in January. And we brought this group together on a weekly, the work groups together on a weekly basis, and the executive team together on a monthly basis. And that became important for managing results. Our CIO was very supportive and very vocal about the fact that we didn't want to make this so large that it crumbled under its own weight. So we had a very well thought out work plan that allowed for us to make sure that we knew what we were trying to achieve and when, and not try to take on more than we could possibly manage. So one of the things, as I said on the implementation piece, is that we created an implementation team, and we've since evolved it into an oversight team, sort of built on the build it and they will come. We created an executive implementation team and then now oversight. These are the members that are there. And these are folks who, some of which weren't on the original list when we were trying to put them together, and we're calling, inquiring, hearing about it and saying, I need to be there. I want to be part of this this team. I want to understand where we're trying to take the organization. And if you hear anything, I think in all of this, bringing your stakeholders together, really important. And this is a group of people that now meet every other month. We had been meeting monthly, but we now meet every other month.
So, James, I'll chime in again here because it seems like a really important thing you did. When I was at eVariant and prior to that and now at Health Grades, we've always advocated for the main users of a solution to have executive sponsorship for these types of implementations and products. But this type of complete cross-section of constituents being in a regular oversight committee might seem unusual to some of the people listening in today. How did that come about, and how has that engagement and participation been? You mentioned that you met every month and now you meet every other month. And has the existence of the committee impacted your other strategic planning activities at all? I know I loaded a bunch of questions in there, but basically, how did it come about, and how participation is, and how has things changed now that it is in place?
Sure, lots of great questions. I would say how it came about is as we were going through the RFP process, and something important to note here is that by the time we brought in and started doing the RFP, we were well into our performance year. So the decision to purchase PRM and to bring it on board was outside of the normal budget cycle. And in order to be able to do something like that and gain approval the first time you go in front of your capital committee, we needed to make sure that we had buy-in at every level. That's how this started, was to make sure that what we were trying to achieve, or what we thought would be a good solution, actually was in alignment with where other stakeholders were, both at the executive and C-suite level, as well as at the local and market level. And so that's how it started. I would say how it sustained itself over time was folks really saw what it does, what this solution can do, and how important and pivotal it was in order for them to be able to achieve the tactics and the goals and the visions that had been set out both in our strategy as well as what were already normal operating plans. And so that's how it has continued. We have grown over time, and I'd say service lines are probably a good example. As a service line became official, that's somewhat new for us at Henry Ford. And as they became official, we brought those folks into this room as they were starting to stand up that service line that was both employed and independent physicians, and representing the kind of intelligence that PRM could provide for them as they were trying to build that out. I would say also that there's a lot of, I've got a lot of new people here at this governance level, but the second part of it is a lot of folks who've been at this for a long time. So we had an opportunity to balance, historical operating models with new vision, and have a pretty healthy place to start having those conversations. I hope that maybe answered your question.
Sure.
Okay. I would say if for the folks that are participating today, if you hear anything that this experience has brought us, governance matters. Both on your solution as well as on your data management. And again, I've run governance for a lot of my career. I've never had the kind of people knocking on the door saying, "Jane, can you add me to that committee?" Because most folks aren't all that interested in giving up even more of their time in committee work. But it's made a significant difference. What did we get? What did PRM bring to the organization? We've just now really started to get into what I term use cases. So people around the organization now that know that this platform exists and that it has a lot behind it, and coming and saying, "I'm trying to solve this problem," or we need this particular information, and asking the question, can PRM start to provide some of that intelligence that they're looking for? And it has provided us with actionable market volume and referral insights. So we now have, the ability to be able to see what is coming into the organization that might not be coming in through that referring physician office, but just happens organically. So we can see that activity. And it also allows for us to be able to see where we might be losing business outside the organization, what I like to call in-system utilization. What are our opportunities there? And where do we have a place where we have significant risk? Have referrals or volumes dropped off? Have we started to see that there is a difference in how business is being done in a particular area? And it allows us to look at it from it's very directional, inside the organization out, outside the organization in. It allows us to do a lot of that. And it is part of a larger strategy that has been laid out for us from our IT and technological folks. I would say the other part that is important about what I just spoke in terms of the governance, I have a partner in this, and I have from the beginning, and I should have mentioned it sooner. While I was gone from Henry Ford, IT made the decision to hire a vice president of IT for physician alignment. I was amazed that role even existed when I came back to Henry Ford, and I sought out to find out who this person was and meet with them. And that partnership was instant for both hats that I was wearing, both PRM as well as my clinically integrated network role. And he and I have been able to really drive a significant understanding about what it's going to take to achieve these results, and where we can sometimes get stuck with not knowing the nomenclature on the technology side. So we bring operations and technology together And I would say that in his leadership, the CIO really wanting us to get to a more firm CRM foundation on both our consumer, our marketing, and our physician relationship structure. And so it's allowing for that to occur.
Jane, if I could, before you go to the next slide, you and I have both been in the claims data-driven market intelligence space for a while. You from the client side and myself from the solution side. And we've seen a lot of evolution over that time, and the journey never ends, right? There is no perfect yet in this space. Could you maybe tell the attendees about one or a couple of recent developments you're excited about, and then maybe what's still really high on your wish list when it comes to market intelligence?
Sure. A couple things. So I'll go with the things that we're excited about, and then talk about where we really need to remain vigilant because we're not there yet. I would say the cool part is people are knocking on the door, sending emails, making phone calls, saying, can you show me what PRM would say regarding this particular issue? And so I'll take you back to, we've got a site in one of our markets that has been probably not a high priority site for the organization. And we've got some services there, not all services there. And so our strategy and planning folks came to the PRM team and said, what can PRM tell us about this? And through the efforts of the folks that get up every day, go to bed every night thinking about PRM, at least during their professional hours, I should say, they were able to take a look at this data and show planning and strategy and the governance. We took this back to the governance group and showed them what services are actually leaving that particular market and where are they going. What are we losing to a competitor versus where are we requiring our patients that are staying within the system to travel further than they probably should have to in order to be able to achieve those services. And so it started to identify for us what services should we be putting in this particular site. Based on that answer, is the site big enough? Do we need to make a capital investment in it? And so it allowed us to see what's current state and then start to build out towards future state. I'd say the other really exciting area is where we have doctors in a particular hospital market. So think about your traditional hospital liaison outreach roles that are predominantly aligned with primary care, looking to make sure that hospital services are what they're looking for and try to maintain that alignment. And oftentimes what happens in our traditional or more historical way, we continue to outreach to the same physicians, and we continue to do some of the same things. We want to remain top of mind for them. This is good work, important work. But what we came to PRM to ask is the data showing us that alignment that we believe is there, really there? And we've started to find what I call question asking data. Some of it is not validating what we actually think is going on. And so we are having more meaningful conversations around that. And in an effort to try to, and very importantly, indicate the integrity of the data. Emilio and team are involved with some folks on the Henry Ford side to do a data integrity evaluation so that we can look at everything that's coming in on our Epic side and be able to validate that we're seeing the same thing on the PRM side. And I would say I'm really excited about that, and not because I expect it to be 100% correct, because it's not going to be. It's data, it's messy, it's claims-based, but it will continue to support what we believe is happening, which is it's directional in nature. And it allows us to make pretty educated decisions about what our next step should be. And so those are the things that are really exciting us on our use cases and in the people looking to have PRM answer some of those questions. The place where I'm not as excited is that we still have a lot of competing source systems of data. And if your organizations are anything like Henry Ford, we have things coming in from our electronic data warehouse. We have it coming from Epic. We have it coming from credentialing. And keeping all of that clean and in alignment is pretty tough. And as we were building PRM, we knew we needed to create what I would call a work group or another committee out of this, which I refer to as our source of truth. And that work has been on pause a little bit, somewhat due to hiring in our PRM team and be totally honest with you, COVID. And we had, so we had to put it on pause, but I can say as early as this morning, have reactivated the need for that group to get off the ground, to start getting to ways where we can electronically keep our data updated, and that the provider data file that we get from health grades that continues to populate for all of our providers in the state of Michigan, that we aren't undoing work. One of our guiding, it's not part of our guiding principle, but I think it is a fundamental thing, is that the last person, in our opinion, that touched the provider and has up-to-date information has the most relevant information. And whether that is a practice address change or a new practice manager that has been hired for that practice, or any other additional information that may be coming in regarding that practice. And if we are going to put that information into PRM, we want to make sure that when a new source system comes in with an update, that it doesn't undo our work. And I would say that is something that we will be working well into 2021 to make sure that we can achieve. Does that answer your question, Emilio?
Yeah, great. And I hope it didn't derail too much from the flow, but I think it's important to know from someone with your experience, what's good and what needs to still be better.
Yeah, absolutely. This is not so this kind of work is not for the faint of heart. I would say a really important thing to remember is it's not a launch it and forget it. This takes continuous feeding and attention. And we are, the other thing, let me add a little bit more about something that I'm excited about. It's a drain on everyone's schedules and it's work lists, but we meet with the health grades team every single week to go over issues, opportunities, making sure that we're in alignment on new data loads. And oftentimes when you buy a solution, you end up wondering, whatever happened with the folks that helped me implement this? Where are they? And that's not the case here. I would say, right out of the gate, some of the folks that were in the pitch when we were doing the RFP are still with us today. Emilio certainly being one of those, and Orville and Carrie. I would say we wouldn't be where we are today without them. And the other part was the unique piece of the partnership that we created. And it was with, for us, because we had an implementation partner in the middle. If I remember correctly, you all had never had that before. And so it was, everyone was agile enough to be able to make that work.
That's right.
Okay, COVID, post-COVID, boy. For those of you who aren't from this area, we here in Detroit got hit pretty hard, pretty quick with COVID. And I would say that I couldn't be more proud of the response that occurred from Henry Ford Health System. But it has, and I'll just share a couple of numbers for you just because I think it's important to put it in context. So we hit our surge in late March and early April here in southeastern Michigan, and that put pause on ambulatory services and certainly on elective surgical cases. And it, as we watched the data daily about where we were, we had over 4,500 COVID admissions. We've had over almost 4,500 COVID discharges. 22% of those people required ICUs, 15% of them on ventilators. And sadly, this is not completely up to date. It's a few days old, but we've lost 639 souls to this virus. And, as we started to get out of the surge and move into our reopening and operating under our executive orders from our governor, we had a backlog of surgical procedures and cases that we needed to get back into the operating room, but we needed to do this safely. And I'm happy to say that weeks and months ahead of schedule, we have cleared out that backlog, and we are, operating at our routine levels. But one of the things that has been interesting is that we've started to see that, folks, especially on the outreach piece, on the ambulatory side, if you've gone to the doctor, I know I have, I'm being seen virtually. Or if, like my mother and father-in-law who are older need to be seen in person, they are, waiting in a parking lot to be texted, to be told when to come in. And the disruptions within the clinic, the outpatient ambulatory space, are being kept to a minimum. That has started to change how things are being done. And I think it's important for us to be mindful of that as we all want to talk post-COVID. We're not post-COVID yet. I will say I remember what we now affectionately term BC, which is before COVID, but we're really having to manage differently, and that it has changed, and I don't know that it's going to go back to the way that it was. One of the problems that we had at Henry Ford and that PRM helped us to solve is that we had a lot of people doing a lot of outreach to the same providers. And our badges are blue, and they would say, you all have a blue badge, but you don't remember who was here last week, or who was just here yesterday. And I already told them something. PRM allows us to be able to see that activity now. What it has also done, though, is really allowed us to start getting feedback from our providers who are not terribly interested in that disruption anymore. Yet they don't want to not be on the inside. And so we're going to have to do things differently. But I would say several things happened during COVID that PRM became useful for. We had orthopedic service line that wanted to make sure that they were communicating appropriately with their referring providers about what was happening with the paused OR cases. And they came to PRM to get some of those physician lists. We had hospital CMOs that wanted to make sure that they were communicating with all of their physicians within their particular market. PRM was a source system for them. And we were able to also, I'm proud to say, Henry Ford is the only hospital in the state of Michigan that is participating in the COVID-19 Moderna study, phase 3 clinical trial. And in the other hat that I wear, I was able to provide information out of PRM to get our providers that are in the network that I manage access for themselves and their patients to that trial. And so the use cases, again, are they're never ending. And so I would say, I believe, though, that things have changed, and I'm interested in seeing what the future holds in terms of how we'll use something like PRM in this COVID environment that we're in. I would say that the other thing that becomes pretty important is that we did, in listening to, let me actually back up, I think I've gone too far. In listening to some of the individuals who I work with closely, the administrators over large physician organizations, and then the service line leaders within Henry Ford Health System. So our service lines are cancer, neuro, heart and vascular, and cardiology. And heart and vascular, cardiology, neuro, and cancer. So the one thing that we wanted to do was, how could we organize ourselves a little differently on how they were going to be trying to reach out to their referring providers and communicate with them. And that's another place where they've started to ask some questions of what PRM could tell them. And one of the things that yep, go ahead, Amelia, sorry.
If I could interrupt, on the prior slide, you had an indication that one of the things that you were going to do is not return to traditional outreach coming out of COVID, that you got some feedback that some of the activity tended to be disruptive, too many people accessing for different reasons, but that they still wanted to be connected or feel connected to the health system. Can you talk a little bit about how you guys have adapted to that sentiment that you captured in the PRM from the providers and said, we need to do something here? And do you see that as maybe being permanent?
Oh boy, if I had a crystal ball, right, about the permanency of that one, that would be, I don't know. Well, let me back up. I've been a practice administrator. So I've been one of those people who would be interrupted by no offense to anybody who came from this background, but from the pharmaceutical model, right, where, came in and started to disrupt clinic flow. So I know what that's like. And I think one of the things that COVID has allowed us to realize is that limiting those distractions and those interruptions has become highly valuable. And we have a lot of providers that are spending an awful lot of their time post seeing patients, still trying to catch up with work. So what can we do to try to help minimize their distractions and interruptions? And so for us, the service lines that I was describing, when they came to PRM to start asking some questions about outreach and what they should be doing, I recommended something that I had heard from a previous colleague, someone that I worked with at Evolent that's now at Caramount on the East Coast, and what they were doing about trying to reach out virtually to their providers at an organized time without disruption. And so what was been really cool to watch is that all four of our service lines have come together to say, we should do this. And we could organize our message so that we're not contradicting each other. We can do it at a prescribed period of time. We could involve the clinical leadership from that market, so say the CMO from the hospital in that particular area. And we can invite multitudes of providers, as opposed to if you were doing a dinner, right? You would want to limit that to a certain amount so that you could make sure that the exchange was intimate. And that is being formulated now. And I have a feeling, and again, this is my gut, but I have a feeling this might become a solid offering for us in the future. And that this, you can get providers to give up an hour of their evening virtually, then 3 hours to leave their clinic, drive to a restaurant, do dinner, all of that, and then drive back home. So I think we're onto something here. And PRM has allowed us to start to use some of those cross-reference of those providers. And we did that and identified a couple of physician organizations within the community where we would like to try this out. And those administrators that are in those POs are helping us formulate what they'd want to be hearing from the providers. And any of you who've been an administrator or work closely with them, you know that they drive results on attendance. And so having them as partners and people to help formulate this approach has been invaluable.
That's great to know. I think, even just in our own relationship, we haven't been meeting face-to-face for over 6 months, but we've maintained our cadence and productivity through our virtual meetings. And it's happened across many other industries, but I think it was great to hear the specific use case that you've encountered and have adapted to.
Yeah. There's significant interest there, and I know that, and this is not meant to any way, I think, reduce the importance and the benefit of the traditional outreach liaison role and that relationship management. I think it's meant to augment it in some ways and to allow for variety on the approach. And it's going to be really important for us to listen to our customers here and document that inside PRM. I mean, we're using our PRM to do any number of things. So back to the COVID piece, we're collecting what EMR platform all of our providers are on. Really important when we were going to virtual visits, and what kind of support did folks need. And the beauty of this is the incredible people on the Henry Ford PRM admin side who hear our questions, and the answer is usually, yep, we can build it. Yep, we can get that in there. Again, not wanting to make it so large that it's not useful, but some of this very, basic information is really important, and it wasn't residing in any one location. So I'd say, just in terms of wrapping this up, the past was very intuition driven, and I led with my gut for a long time in this space. And it wasn't until I started to see what a standalone CRM could do that drove us to a system-wide PRM solution to know that, data-driven decisions is in the future for everyone. And we, as I indicated, a new operating plan, a lot of new leaders in the C-suite. We are oftentimes having very meaningful discussions about new programs, new products, new opportunities. And it's not uncommon to hear now physician leaders and executives say, how has PRM informed this new strategy? And in many ways, it doesn't get a lot better than that, right? So that we have been able to permeate the organization in such a way that people are asking questions about what sort of intelligence can PRM provide. So it's don't go anywhere without your data. So with that, I think I'll hand it back over to Emilio and let you take it from here.
Great. I think we're doing really excellent on time, and I think the folks at Becker's have collected some good questions that hopefully you and I can answer. Just a quick comment about Healthgrades. As I mentioned earlier, Healthgrades acquired eVariant at the beginning of this year, and that really kind of rounded out some of the offerings of the company. Healthgrades today is an enterprise scale solutions vendor in the space of consumer, patient, and provider engagement. Today's discussion was really focused on provider engagement and provider intelligence, market intelligence. But there's so much more that Healthgrades does, and with the bringing together of eVariant, it really focuses now on all three aspects of engagement that's going to drive growth going forward. And I think what's critically important, because the topic of today's conversation was data-driven market intelligence that helps drive strategies for provider engagement, it's important to note that data science and artificial intelligence and all these buzzwords about is the art of the possible is really what we are passionate about. And as we go forward, we're going to be looking to leverage the massive quantities of consumer, patient, and provider data that we hold to help support our many health system clients. So with that, I'll turn it over to the Becker's group to ask us some of the questions that came in.
Wonderful. Well, Emilio and Jane, thank you so much for such an insightful presentation. Like Emilio said, we'll now begin today's question and answer session. Please submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen, and we will try to get through as many questions as we have time for. We've already had a ton of great questions rolling in. The first is from an audience member who says, with the growth of value-based reimbursement models that require strong continuity of care and provider collaboration, have you found this PRM system has improved your system's performance in these payment models?
Certainly, I can take that one. I would say that we have not, our performance in the payment models and how we're using PRM, those don't cross. So in terms of what I will say as our collaboration and our communication and our opportunity to keep our providers informed. In my other hat that I wear in the clinically integrated network, the director of our network management and the outreach, we call them practice transformation specialists, they all have access and work in PRM daily. I would say one of the major areas where it has influenced our performance is in, for any of you who do this work, we are in the constant thing of list making. PRM got us out of list making with Excel spreadsheets and rogue databases and sticky notes, and allows us to be able to have our provider network and our provider directories pulled from PRM. That's where it's influenced it early on. And then when it comes to performance on contracts, we keep that kind of documentation separate.
Got it.
Great.
Thank you for outlining. Go ahead.
And the other thing that I might add to that is there are some emerging technologies, one of which Healthgrades is implementing right now, that allow us to really kind of shift the lens on these solutions and what we do with claims data, and create a patient-centric view of all the claims history of a patient across payer changes as well. And that's a bit different than in the past, where the focus was typically on the most complete piece of information that existed on a claim, which tended to be just the provider identifying NPI. So now we are, kind of entering into a new era where I think there's going to be a lot of positive development for value-based care intelligence driven off of market available claims data.
Yep. Very exciting.
Definitely. And Emilio, let me stick with you for this next question, which is, what is the origin of the physician referral data?
That's a great question, and I guess we didn't really cover that in depth. When Jane and I talk about claims data-driven market intelligence, essentially it starts with acquiring as much relevant claims data for a given market as possible. And there is no 100% source. You have to bring this together from in different ways. But generally, referral data does not exist in much completeness or accuracy within that purchased claims data, because it's not necessarily required for the vast majority of clinical services to have referring information in order to get reimbursed. So at the end of the day, what these market intelligence solutions do is they calculate the likelihood of a direct referral taking place. And then I'll circle back and say that's part of the benefit of this new technology that's providing a patient-centric view. It's that the algorithms, the calculations of whether a PCP referred a patient to a specialist or whether that patient just ended up at that specialist, that intelligence and that accuracy is improving continuously. So the short answer to the question is they are calculations. And over time, they have gotten much, much more robust and accurate. And they remain directional because they don't represent 100% of all clinical activity.
Got it. Thank you for providing that background. I think that's helpful for our audience to know. We've got another audience member here who is asking if you could share additional information about some of the specific features that was used in the platform and what specific problems did it solve, such as adherence to quality metrics.
Again, on the quality side of this, and forgive me if I've been confusing folks because I do wear two hats, we calculate our quality metrics and our performance outside of PRM. And so I think as far as some of the specific areas that we focused in, we really needed to get our affinities correct in PRM. And I failed to mention that earlier. When you do this and you have the provider data file that's coming over from Healthgrades, and we have other source systems, being able to identify who's employed, who is affiliated. Are they in your network? Are they not in your network? Are they on staff at one of your hospitals? Do you consider them aligned? And then how do you use that information and those affinities to start to pull the data forward to tell you, to give you a snapshot or some sort of a composite of what that physician's alignment looks like to your organization? And so I would say, again, on the quality and population health performance side of this, we do not, because one of the things that's really important about provider performance is that there is a level of data integrity and confidentiality that we need to maintain. And one of the things that is the beauty of PRM is that any user on this platform who has license to be able to see across all three of its components, right? The provider data file, all of the activity that's being completed by individuals who are doing outreach, plus the solver, the market intelligence solution, they can see that information across the entire domain. And if we were going to be putting information in there regarding physician performance, we would have to have a lot of safeguards in there in order to be able to manage security on who can see what. And so that is not where that information resides for us in the clinically integrated network.
Great, thanks for clarifying that, Jane. The next audience question is, what is being discussed at the PRM Exec Oversight Committee?
Oh boy, a lot of what I just described about affinity. I would say our physician leaders really took a lot of time. We posed different scenarios for them on how we would be identifying what sort of call it a label, call it affinity, whatever, to describe the kind of a relationship a provider has with us. And then what does that information tell us, and then who needs to tactically act on that information. And I would say that is a big one. The other big part that we spent a lot of time on, we created a policy around PRM that was signed by our chief legal officer within our organization. She will continue to say that physician relationship management is both our biggest opportunity and our largest risk, right? This information, especially if you're looking at the claims market intelligence, it has to be used thoughtfully. It has to be used for the purposes of driving programs and market intelligence. And I would say we spent a lot of time talking about our policy development and the proper use of PRM, and that this needed to be bringing our providers and our community closer together because of the intelligence that we have, certainly not meant to drive us further apart.
Great, thank you again, Jane. This next question reads, does or will this extend into and help enable population health efforts?
I think it will in the long run. I think that it has a great opportunity to do that. And we use PRM to identify those individuals that are in our network and who participate in certain contracts with us. And so it will absolutely have that opportunity. We have not moved into a CRM, kind of PRM capability in the population health space. I think it is it's certainly on the horizon, but we have not gotten there yet. But it has extraordinary potential.
Yeah, and I would add that, from the enterprise solution standpoint, that's certainly what Jane referenced, that the CRM and PRM coming together for both initial engagement with a population that is assigned to you, continuing communication and engagement with them, and then looking at general patient journeys, the patient flow, is going to be critically important. Now, one of the things that is still being worked out is that when you participate in population health and value-based care contracting, most typically clients do get some access to patient information and claims information from the payer for that subset of population. And yet the rest of the market data is patient de-identified. And so that's where in the future, the patient-centric model of looking at the claims data is going to be critically important. There's also an emerging technology called tokenization that can take different data sets, whether it be from the client, from another third-party payer that there's a specific contract for, or the sourced claims data that Healthgrades purchases today, and that can be brought together with this tokenization technology in order to do highly accurate master patient management so that you're not engaging in duplicate information as you start to bring all these different sources of data together. So good technological developments on the horizon in that space.
Perfect. looks like we have time for one more quick question. This is from a provider relations manager for a clinically integrated network that is part of a health system. And this individual says they have a separate physician liaison team that focuses on service line growth as opposed to the growth of the clinically integrated network and network contracts. And the question is, do you believe there is a benefit for the teams to work under one umbrella?
Oh, boy, that's a good question. And that's part of what I was getting to when Emilio had asked me, what are we excited about and what are we challenged by? I do believe this is not about moving, like reporting lines or, title changes, but there is a significant benefit of folks, as described in the question, coming underneath a more comprehensive umbrella. And that is something that I think Henry Ford, we brought the solution. I think that the solution is going to continue to ask the question about our structure. And if I were able to paint a new landscape as it relates to this without causing disruption, but creating an increased collaboration and coordination of services, because we're all still touching the same doctors, depending on what lens we're looking at it. But these are the same providers. I highly encourage to bring them underneath one.
Wonderful. Well, Emilio and Jane, thank you again so much for such a fantastic presentation, and thank you to HealthGrades for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.
Thank you.